Good afternoon. I am Samir Mehta, the course director for Lumen Global. We are having our 19th annual symposium in Jaipur, India. During the Lumen Global meetings, we conduct several YouTube interviews that would be performed tomorrow morning. Today I am having chats at Lumen Global with notable Lumen Foundation directors and eminent cardiologists from around the world who have assembled. The meeting again starts formally tomorrow morning. The first person joining me today is from Ottawa, Canada, Dr. Michel. Michel, welcome to Jaipur.
Thank you, Samir.
You probably have been at least a dozen Lumen Global meetings, and I remember meetings in Dubai and Bangkok and New Delhi and Kuala Lumpur,
yes.
And of course in Miami.
Of course.
Dr. Limay is the director of the STEMI program at the University of Ottawa, and he was also the recipient of the Lumen Global Achievement Award, I believe in 2016.
That's correct. That was
in Bangkok.
In Bangkok, yes.
Wonderful. Michel, there is so much relevance of your work to India and to the Southeast Asian region. Particularly, I say to India because India is a very large country, not unlike Canada, although with a population of several dozen-fold, maybe even larger. How does some of your work translate into improving STEMI systems in India?
I think that we've looked at some of the very basic principles in dealing with patients that present with STEMI. And as you know, time is really critical in taking care of these patients. And we had the opportunity of starting, as you mentioned, with perhaps a smaller population and getting the logistics looked after in terms of getting these patients quickly for treatment. And what we've learned is that we can either use reperfusion with fibrinolytic therapy if the patients are at a distance, or we can use very effectively primary PCI. But in order to be able to use these two strategies, I think you need to tweak the system. And I think that you need to look at the logistics. You need to ensure that the patients are treated in a timely way. So there are many steps that we've taken in order to standardize the system, and we've developed a STEMI system. This same kind of STEMI system, the principles that govern it are the same that could apply to India. And I think one has to look at one's own set of geography, population, and assemble a type of team approach that involves a region in order to best deliver STEMI care.
So last year after the meeting, we put out a manuscript in the Indian Heart Journal, and we realized that there were two major issues. One, exactly what you mentioned, there was a lack of STEMI networks. And the second was that there were tremendous system delays with patients presenting extremely late. There is a study performed in India which has figured out that the mean time to presentation is a little more than 6 hours. In some ways, that challenges a pharmaco invasive pathway also, because if a patient is presenting at 6 hours, you are scientifically even out of the most optimal thrombolytic therapy.
That is correct, and I think that, Samir, what you are doing now is highlighting the importance of getting to the patient very, very quickly. But it also highlights that there's a huge educational component that we have to deal with, and that information has to be disseminated throughout the population. And that is at the level of physicians, it's at the level of nurses, it's at the level of EMS, it's at the level of schools and our governments. And in some ways, we need to get the message out that patients that present with chest discomfort, that needs to trigger a call, a 911 type of call, in order to get medical attention. And this is a big, big and educational endeavor.
Now, we've been doing the Lumen Global meeting in different countries. In some ways, no country is similar. they have their unique challenges. Even within the country, we've had meetings in New Delhi versus doing it in Jaipur, which is India's largest state of Rajasthan, and the dynamics are totally different. How do you address that? How should people approach this differently?
I think that you go to these meetings, you take back some very basic principles, and you go home, and then you look at your own environment, and then based on what you know in your own backyard, you adopt strategies that will best deal with your own environment. And there's differences worldwide. The geographies are different. The populations are different. The level of education of people are different. The access to PCI hospital is different. The equipment that we deal with, that we have at our disposal is different. The pharmaceutical is different. For example, some, tenecteplase may be too expensive for some areas. And yet we know that drugs like streptokinase work very, very effectively. We've seen a major reduction in mortality of an absolute at least 5% when the GISI trial was done. So I think that it's very, very important to recognize these differences, and you won't have two systems that are identical. And that's why we meet together like this to discuss what can we go back home, what have we learned from these Lumen meetings that allow us to go back home and then implement something that is novel, something that is brute, but basically tweak our system in a direction of getting these patients to faster medical care.
So just as an update, tenecteplase actually is generic in India at a fairly low price, and there is a fairly aggressive campaign to make it available to the people. Yesterday was also a most dramatic day for healthcare in India. In many ways transformational, because the union government, they have an annual budget which allocates fund, and there has been a provision to cover as many as, and this will surprise you, twice the population of Canada. That's 50 million poor people are now going to be brought within this scheme, and it's not by American standards, it's not a large coverage, but rupees 5 lakhs, which is a fair amount of money in India, is going to be allocated for them to obtain care. And when I read the news, I thought that was very positive for PCI in India, for primary PCI, STEMI interventions. And what does something like that appear to you?
I think that's a very, very important step. I think to get access to care and to be able to use these pharmaceutical agents in a greater number of patients. I think that this eventually snowballs, and I think that that's really critical. That once you got the momentum behind you, once you are able to get strategies into place and recognize how important it is to treat these patients with very early reperfusion therapy, I think everybody recognizes that. And then, you don't need a p-value after a while to know that these patients do much better when they get, in the hands of the medical profession and they get, expert care.
So, Michel, one of in the same work which we published with the Indian Heart Journal, it is quite obvious that one of the biggest challenges in a country such as India, and specifically India, is the lack of organized ambulance care. How does one get around this very difficult situation?
That is a very difficult problem, and I think that funding has to be delivered at that level. There has to be funding in order to get better EMS care, and I think that there are different ways of adjusting for that. I think that simplicity sometimes you can have something as easy, and I think in Singapore they were talking about using motorcycles, for example, to get around traffic. I think that, again, educating more people in the ambulance people is so important. EMS is critical in any STEMI system. And if you go worldwide, when you look at the very, very best STEMI systems, EMS has to be engaged. And so I think that you can go from the ultra modern and sophisticated system with lots of toys and all that, and then you can simplify. For example, in our jurisdiction, we don't transmit the ECG. We train the paramedics themselves at reading electrocardiogram. So
your advanced paramedics, no?
The advanced care paramedics and now the primary care paramedics know how to read the ECG. And in fact, if you, these, again, it's an educational issue. I think that once you get beyond that and you teach your EMS how to read ECGs, you can simplify it in that you don't need sophisticated communication systems in order to transmit an ECG. You can just call it in the field, they can call you, and you can assemble your team while you're waiting for the patient. So I think that I think simplification sometimes is very important.
Michel, as one is disseminating such key information to raise public awareness, as well as to get STEMI networks of various shapes and forms, specifically answering to the needs of a particular population, what is the role of cardiology and the other national medical societies?
Well, I think we have a big role as a society, as part of a society, and being a cardiologist, to take part in educating our public, increasing the level of awareness of STEMI care, the urgency of getting patients out. I think, I remember many years ago in the U.S. there were commercials for hypertension, and on a regular basis we saw very, very short commercials on television for hypertension. And I think that this is just an example of what could be done at the level of STEMI care, where there's a need to educate the population, get the message out there. Colleges, medical colleges have that responsibility of teaching their local population in order to decimate this very, very important message of when you have chest discomfort, you've got to get medical attention, and it's got to be done fast. So I think that at the level of schools, at the level of, it can be implemented as well with the very young learning this, so that the next generation has that level of education. So there is an opportunity to focus also at the level of high schools and primary school, so that this generation, when they grow, they will understand the principle of getting in touch with medical care, calling when they have a problem, getting to the hospital. Sometimes you don't necessarily have access to the EMS, but at least you can get to the emergency department. And whatever your local emergency department is, you've got to be able to get there. And so I think that at the level of population, it's very, very critical. And then we have a role to play also in educating all of our EMS, our nurses, and our staff about the importance of time. It's very, very easy to become complacent about STEMI until it gets too late. And I think time is always very, very critical. And so it is important that we also promote the level of education at the level of the medical staff as well, our own colleagues.
Excellent. Now, your contributions to STEMI interventions have been manifold, from creating the first amazing model for Ottawa to where I think your work has had the greatest relevance in the United States, of course Canada too, has been the dictum that a patient, when he's picked up by an ambulance, should be taken to the primary PCI center as opposed to the nearest hospital. And you demonstrated very convincingly that there is also a reduction in mortality. Talk to me about that, Michel, and specifically, how does one translate such an important message in India and in the entire Asian countries, parts of the Middle East and Africa?
So I think that the way we developed our system is that we became keenly aware that reperfusion with a primary PCI could be done if the patient could get to a primary PCI center in a timely way. And so we had gone through a process with research and working with our EMS of developing the ability amongst our EMS staff to read ECGs. So that was a very first step, is the interpretation and the recognition that you can get an electrocardiogram in the field before the patient reaches the hospital and make the diagnosis very early. So that was a very, very first step. And then we had to put together a number of logistical steps in order to ensure that the system would work. And so what we did is we engaged all the local emergency departments. We engaged the CEOs of different hospitals. We got them together in a big boardroom. We talked about the evidence that had surfaced, such as the DYNAMI trial, which showed that within a country, people could get organized to transfer patients, inter-hospital transfers, and transfer directly to PCI hospitals for primary PCI. So we looked at the DYNAMI results. That was very, very important. And there was also the analysis from Keeley and Cindy Grimes, that came out around 2003 that showed that when you look at all the trials that have been done with comparing primary PCI to fibrolytic therapy, that there was an apparent mortality benefit in doing primary PCI. So recognizing that other people could do it, that other countries could do it, the DYNAMI 2 study, and recognizing Keeley's meta-analysis, we decided we had to put together some logistical steps. So we engaged our community, emergency physicians, cardiologists, CEOs, got them together with evidence-based medicine, and we decided we'd take it from there. So the first step, we decided, let's start from the field. That was the easiest step because it was the most obvious step. And what we did is we started in July of 2004. We set a fixed date to open the program. We had arrangements where everything was to be standardized. There was a number to call. For example, when EMS would pick up a patient in the field, they would have a number to call, like a 1-800 number. But it was basically they were calling the PCI center, and it was only one number, and it was preset in their phones. So they didn't have to look for the number. The number was preset. All they had to do is place the call once they had diagnosed the STEMI. And then once that call was placed at the center, it did activate the team so that everybody had to assemble. So then we had to say, well, where are they going to assemble? So we designated a particular room, with a bed and a monitored area, like a mini emergency room, that what we called it a STEMI room. And so when the paramedics would arrive, we had posters in the hospital showing where they had to go. And so they'd come to the STEMI room, and the team was already assembled there. A cath lab had been designated as the lab that would be doing the procedure. And so once the diagnosis was confirmed in the STEMI room and certain protocols had been taken place in terms of medications, then the patient was immediately sent to the cath lab. When we realized very quickly within a year that system was working very well, we decided to expand. So there's a principle there is that you can't start really big. You got to start small. And we started small from the field, from within the city alone, and then we expanded to the city hospitals. And then the inter-hospital transfers were set up in the same way with protocols for each emergency department, and everybody got on board to use the same kind of standard medication. So we transferred the same call, the same operator at our PCI center in order to transfer that patient and get them over to the PCI center. So we now had included we were now including as an inter-hospital transfer, the local hospitals within the city. And then the next step was to stretch out the boundary. So we pushed the boundary out further and got all of the small community hospitals within a certain time distance, where we thought that with no more than a 1-hour drive to the Heart Institute or to the PCI center, we included those. And then we had to draw another ring around that inner circle to include those patients that could not reach the PCI center.
Almost what Tim Henry had done many years ago.
This is very similar to the Minneapolis model.
Look, so many lessons from what you've just mentioned, including something else which you have when you talked about the different people getting together, the stakeholders, I think
Yes.
that's an
Yeah.
important issue. Michel, last topic for you, I need to get an update on hypothermia. What's happening with that, and what is its relevance for other countries in the world?
So I think that we practice we developed. It became apparent that once we had our STEMI program and our STEMI system, that we had to graft on top of that a cardiac arrest program. And as you know, a lot of there are some STEMI patients that present with cardiac arrest,
Many.
and they are going to be transported to your cath lab, and you have to have a protocol for those people. So currently, we develop a program for patients that have return of spontaneous circulation, that's ROSC, after having a cardiac arrest. And we basically have designated our center as a cardiac arrest center in such a way that we serve our region. And so when these patients come to the emergency department, they are triaged and they are transferred to the Ottawa Heart Institute. We cool these patients. We have studies, ongoing studies, but it has been also a standardized approach to take them all to the cath lab. We believe that that working in the cath lab, we can manage all the STEMIs, and we can uncover some patients that have also a silent STEMI. And interestingly, the electrocardiogram is not always evident in the context of a cardiac arrest, and there are some patients that will benefit from angioplasty. But there are things that happen in the cath lab that include management of the patient, getting the lines in, making sure that we can put a cooling catheter in the patient. We used a cooling catheter, so endovascular cooling. It is put by expert hands to minimize the chances of bleeding. We will put all the catheters, the Foley bladder catheter, the nasopharyngeal catheter for monitoring temperatures. We will ensure that the tubes are all well placed, the endotracheal tube. We send blood gas, electrolytes. These are all sent, and so the cath lab becomes like a mini critical care unit for some period of time when all of the attention of the team is actually there to take care of the patient. And then the patient is transferred to the cardiac intensive care unit where the patient undergoes therapeutic hypothermia. We manage this patient. We keep him cooled for at least 24 degrees, and then we gradually warm him up and then maintain normothermia. Altogether, protocol is similar to the TTM trial where we keep him cool for approximately, the protocol lasts for about 72 hours altogether with the cooling and the rewarming and the keeping them at normal temperature. So this is, now we are moving to have all of the VFib arrests for the region move to one center, and that's the hospital, which is just adjacent to our PCI center. So the two connect by a hallway, and we feel that patients would be better served by developing a expertise at the level of the emergency department at one single hospital where all of these VFib or VT arrests, the shockable rhythms, come to one single center. And again, this is part of standardization. And these patients are so critically ill, the cardiac arrest patients, they are really, in order to be able to, their prognosis for one is not as good as the regular patient. And therefore, they are really in need of more advanced critical care management.
Michel, thank you. It was a wonderful conversation, the first one to begin at Lumen Global.
Yeah.
Thank you for your wonderful support, and we'll get you very active in the next 2 days at the Lumen Global meeting. Thank you.